over 200,000, we had less positive cases than tests from 80,000. What does that mean? Does it mean that we have a community spread? Of course we do have a community spread. But does that also mean that all the safety protocols, and in fact the measures that we've been putting in place and trumpeting, in fact, does it mean that the measures that were put in place earlier that made us a beacon of hope when it comes to dealing with COVID-19, earning applause from all over the world, are currently not serving our best interest? What is happening to our number of tests? Well, we used to do pool testing. We said that was the best thing to do, considering our circumstances. Are we still doing the pool testing? When we started, we had 2 testing centers, and then 7 more came on board. We said that was a way of ensuring that we could test more. In fact, we had talked about the enhanced testing, we had talked about the contact tracing, and we said we were going out there to find the virus, to make sure that we deal with the virus. Are we still going out there to find the virus? Are we dealing with the virus? This is our discussion for today on Upfront. My name is Winston Amwa, and I'll be introducing my guest shortly. We'll be getting into everything about the testing, why we're facing the challenges that we're facing. In any case, is it that, we're testing less and having more cases? Well, the figures seem to suggest that. So what are we not doing right? When we return after the break, I'll be introducing my guest, and I'll share more statistics with you. Today, we'll look at the numbers, and we'll look at our testing. We'll be right back after this break. All right, so welcome back from that short break, and thank you very much for staying with us. This is Upfront on JoyNews channel, and my name is Winston Amwa, and today our focus is on Ghana's COVID-19. So we have in excess of about 18,630 cases. What that means is that our case count keeps rising by the day, and there's a country that had actually gone out there initially and said we were facing the virus, we're going out there to look for the virus, and so the spike you saw in cases was as a result of the country dealing with the virus. Can we still say same as of today, the 2nd of July? Well, my guest is a virologist at the Kumasi Center for Collaborative Research, that's KCCR, Dr. Michael Owusu, who's joined us via Zoom. Dr. Owusu, good evening. Thank you very much for joining us.
Good evening, Winston. Good evening to your viewers.
Great, and thank you very much for joining us. So we know that when we started, yes, it was KCCR and Noguchi. Then other testing centers came on board. Currently, we hear those testing centers are no longer testing. Has it gone back to KCCR and Noguchi?
Yes, so I also listened to the interviews by the Director General of Ghana Health Service and also my colleague at Noguchi. Well, just to take it from what they said, it's not surprising because of the demand for logistics for testing across the country. As you already know, we started with a very low prevalence of the virus, and as at the time we started, there was this aggressive testing. Because the prevalence was low, we were able to test as many samples that came to our facilities. And along the line, the government, through KCCR and Noguchi, also added some other centers. But what is known about the virus is of course, as the prevalence goes up, certain techniques will have to change. There's a demand for increased resources in terms of the various logistics needed, which you need to assemble together to enable you to test. And looking at the prevalence that we are seeing now, it's not surprising, this should be expected, that as the prevalence goes up, the capacity also goes down, which will mean you have to either add on more or you have to look out for other sources from wherever you can find and boost your testing capacity. So this is something what the virus does in many countries.
We will come to this analogy that as the prevalence goes up, but you talked about demand for logistics. What is that challenge with demand for logistics? We don't have enough testing kits?
We have, when we started, we were testing at a certain rate, close to 3,000 to 5,000 tests per day. And this is because we could test many samples with limited resources. So, for instance, you could process 10,000 samples as 100 samples, which would mean that if you are given 100 test kits, you can work on 10,000 samples. So you can put together all the different components of the reagents, from extraction of the reagents to getting your pipette tips to assembling your PCR machines. And quickly you can run through this and get it done and release results for 10,000 people just about maybe 24 hours to 48 hours. This is easily, and this can be done. But then as the prevalence goes up, that technique for assembling reagents, you will require more things to do. So if you need 10,000 pipette tips to process 100,000 samples, now you just need 10,000 pipette tips to process 10,000 samples. This is the reality. So initially, when you have many logistics coming in to process few samples, many logistics coming to process more samples, now you need many more logistics to enable you to process many more samples. And that is the difficulty. Coupled with this, there also has been challenges, across Africa, especially for Africa. We don't have manufacturing sites for reagents. And most of these are things that we import. Most of the imports were coming from the US and also in Germany. The Chinese, until some time now have relaxed their own systems, and now we are getting something from them. So some of the European countries have placed embargo on some of these kits. And the African CDC has been working with the WHO to just convince these countries to enable us buy from their market, but it's been very difficult. So now that we are in the acceleration phase where we need more of those kits, we are now beginning to feel this challenge, because what we used to get could process our samples. Now we need almost 2 or 3 times that number, and therefore you need to buy more. But when you have the money and even you can't find these to buy on the market, then it becomes a very, very difficult situation to manage.
So we don't have enough testing kits?
We don't have enough, as I said, and it's not as if we cannot procure. I think that the challenge of getting these readily from the market is something that various the government is trying to deal with. So you may have the money, as I said, but how quickly to get this is difficult. Remember that North Africa, Egypt, Algeria, and places like Tunisia, and even South Africa, which is recording quite high number of cases, also need these same kits. And these countries are competing with us. So all of us are scrambling for this reagent. And this is why we seem to be in this difficult situation. But I think the ministry has placed some orders, and I hope very soon these things will come in. I'm also aware that the government initially promised to bring in about 140 GeneSpect cartridges. All the regional hospitals have GeneSpect machines. So I'm aware that about 2,000 of these kits are already in the system, and the machines are being calibrated. So perhaps from next week, when these regions, when they take off with their testing, it is likely that they reduce the pressure on Noguchi and also KCCR, so that we'll be able to deal with the few that come to us. So
currently, on the average, how many tests are conducted at KCCR?
So KCCR, during the early days, when the virus first came in, somewhere in March, in April, we had a capacity of about 2,500 tests as at that time. Now, our capacity is about 500 to 800. Luckily for us, we are receiving samples within that range. So we have not yet exceeded our capacity, but it's possible because the samples are still trooping in. If at any point in time we hit the thousands, it is likely that we may also begin to go through the initial phase of backlogs and have things stored. But for now, we are able to release results within 24 to 48 hours. And occasionally, there may be 1 or 2 samples that we may have to delay a bit, but on the average, we are able to deal with the few that come to us.
Did you say you're able to release results in 24 to 48 hours?
For many that come to us, we are able to, but sometimes, occasionally, we still have some that can go to about a week. And, we prioritize testing for our facility, and we work in conjunction with the regional ministry, the Ghana Health Service and Public Health Division. what we think is most important for us is to channel our resources to the hospitals where patients are sick, and need this test. You know that also when somebody becomes positive, you have to go through and do contact tracing and collect samples from their homes and then bring this together. So, on the balance, we feel that channeling resources to those at the health facilities is much important than those that are perhaps well and are maybe not experiencing or not expressing any symptoms. So somebody who comes in and is asymptomatic, you may get your results delayed a bit, maybe about 3 days or 4 days or maybe up to a week. But those from the hospitals are those that we feel we have to process their results as quickly as possible.
Okay.
So when their samples come in, we give those samples priority, and we are able to release the results at least within about 48 hours. Sometimes goes up to about 4 days, but within 48 hours, we do our best to issue and release these results to them.
I'll get to Kwame Sapon-Siedu shortly, but so in effect, we're not testing enough as we used to do when we began this whole COVID testing. What happened to the pool testing that we had talked about earlier that was something that we're doing?
Yeah, so the pool testing is a PCR technology that you use. What it does is that if you have a prevalence of below 5%, you can put 10 samples together and run it as a single sample. So if I have 100 samples coming in, I can group these 100 samples into 10. And for every 10 samples, I will test them as one, which will mean that if I need 10 kits to test 10 samples, I'll only use one kit to test that 10 samples. That they will be able to release results to these 100 people. So if you group these 10 samples into one and you run it, it is possible because your prevalence is about 5%. It's only 5 of the wells that will show positive, 5 out of 100. Then you can go to these 5 and further break it down. You get maybe about 40 or 50 and run them as single samples and then release the results to the patients. But then as we speak now, because the prevalence has gone very high, and as I said earlier, we are doing about 20 to 30% positivity for every 100 cases that we run, compared to previous where we're doing about 1 to 5%. So now you cannot group samples into 10s again. If you group them into 10, every single one will be positive, which means you have to go back and run them as 100. And that is duplication of effort, and that will be a waste of resources. So if you have 100 samples coming in now, you must run them as individual samples. So that will bring a bit of delay. So initially, if you could process 100 samples in about 6 hours, now you can process the same 100 samples in maybe about 48 hours. This is how this whole technology works.
When you talk about now the prevalence rate of about 15 to 20%, I'm just looking at the figures, and if I look at up to June 29, where we had out of the 80,695 tests we conducted nationwide, and these are according to the Ghana Health Service website, we had 9,837 positive cases. That's 12.2%. So with that 12.2%, you're saying we cannot actually do pool testing, right?
Yes. So, and what you have mentioned, the figures you have is a combination of asymptomatics and symptomatic patients. So if you want to look at symptomatic patients, the prevalence is higher than what you mentioned. So for those who are coming through the hospitals, is more than 12% that you mentioned. It's doing about 20 to 30%. And I'm sure in the coming weeks, it's going to be more than that. For now, for every patient who comes to the hospital with influenza-like illness, either is coughing or sneezing or has respiratory disease, there's a high probability that that patient may have COVID. And therefore, those patients will be directed to the labs to go and test their samples. And when they test, there is about 4 in 10 chances that these patients will show positive.
Okay.
So if you begin to see this trend, then of course you have to amend your protocol in the lab and go back to what you used to do earlier, which will mean running them as individual samples than putting samples together.
But if you look at, before I get to Kwame Sapon-Siedu, now, during the period of mandatory quarantine, if you look at the number of persons that tested positive, out of the over 1,115 persons tested positive, that shows a positivity rate of more than, you know, the 5% you talk about. But at the time, we're still doing pool testing. Is it then the case that what we did at the time was wrong?
The pool testing is not based on the population prevalence like you see on the screen. The pool testing is based on the prevalence you see on a daily basis in the lab. So before you do the pool testing, you need to come up with a protocol, an SOP to guide what you do. You first of all have to run samples as single individual samples for about 3, 4, 5 times. And then from your own setup, find out for every 100 samples, how many positives you get. So as at the time we had these numbers, 115 and over, we in the lab were having about 1 to 2 positives for every 100 samples we run. So that was more like an incidence positivity based on new cases, based on samples that we get on a daily basis at the lab. So because of this, we decided to come up with a protocol. Noguchi, of course, started and shared their protocol with us that looking at what we are getting on a daily basis, which is what they're also getting, let's begin to have a harmonized protocol and then group our samples, first of all, into 10s and run them. At the point in time, we had about maybe 3 out of about 100, and therefore you have to now reduce to running them as 5 samples for every well. And now if you have about 30 out of every 100, then of course you have to go back and amend the protocol and run them as single samples. So we don't deal with, not based on the population figures as in global prevalence, but this is based on what we see in the lab as samples coming in and then trying to look at more of an incident positivity based on what you receive on a daily basis in the lab.
Okay.
This is what informs us as to how to make our protocols, amend them, change them, adapt them, and keep moving around with them until we get something that we feel can work very well for us.
All right, so I'll get back to you, but you know, let me get to Kwame Saponseri, who is a pharmacist and is also a fellow of CDD Ghana. He's based in the UK. He's joined us. Kwame, thank you very much for joining us. Good evening.
Good evening, Winston.
Great. So, you know, Ghana, when we started testing for COVID-19, we put in place measures. We talked about enhanced testing, routine surveillance, contact tracing, mandatory quarantine, and we seem to be that country that was doing so well. By end of May, we had tested 219,000. And then by end of June, by 29th June, out of the 80,000 that we tested, we have 9,837 cases. In fact, it is more than the period from March to May 2020. Why are we seeing this? What aren't we doing right?
It's not about what we are not doing right. For me, it's about what we could improve upon. The point is, if you have a disease that is as contagious as COVID is, you need to have the right behaviors from the general public to decrease spread, because you are dealing with a microorganism that has a generational time of 1.5 days, which means that if someone is infected, Michael will tell you that that person in 1.5 days, if no measures are put in place, would spread it to 3 people. And those 3 people would spread it to another 3 people each, which is 9. Those 9 would 27. So within a short period of time, it would spread rapidly. What is happening is our behaviors in this pandemic have not been commensurate with the crisis we find ourselves in. So we are aiding spread. And for as long as we continue to aid spread, the positivity percentage would continue to go up. And as long as it continues to go up, we'll get larger case counts and more people would feel ill and more people, unfortunately, might pass away.
What about our behavior is aiding the spread? I mean, we've been told to social distance, we've been told to wear face mask, and lots of people do these things. And so what is it that we're doing that is aiding the spread, Kwame?
Well, if you look, today I've seen some footage from various polling stations and all that. And I'm quite sure as a press person, you've seen more than I have seen.
Sure, I have.
Regarding how people are behaving. And we've seen some good practices, and we've seen some very abhorrent practices as well. And if you have an infection and you went to that polling center and you took off your face mask and you were in close proximity with people, even though you are in an open environment, because with this virus, it is known that it is transmitted quicker in a closed environment where ventilation is poor. But in the same light, if you are in an open environment where you are all bunched together, like we've seen in some of the videos, then the chances are that you would spread it to other people. And that is the problem we are having. I mean, before even this registration started, we're seeing it in our marketplaces. And we see footage of people who don't even believe that we have a problem on our hand. And therefore, it is not surprising that we're having, I mean, Michael might be seeing more because he's at the test center. But even if you go on the Ghana Health Service website and on the day-to-day basis, you compute the positivity for the composite data that's put up, that is any tests that have been done by KCCR, have been done by Noguchi, have been done by, say, the Public Health Reference Lab, or any of the other testing centers. I know some are rolling back because of lack of supplies. But if you put it all together, often our positivity rate, especially in the last 7 days, has been over 15%. And so if you are getting such numbers, then you have to realize that you are not behaving properly. And we cannot run away from that fact unless we begin to behave properly, unless we begin to take this pandemic seriously. The numbers would continue to rise. Whatever we do, we can hold press conferences, we can hold seminars, we can speak. Unless we manage to transmit the information we are putting out in the public to a point where it becomes education to the receivers so that they engage in attitudinal and behavioral change and start practicing social distancing, wearing their face masks regularly, avoiding crowds, we are not going to get out of these woods. Okay.
So let's look at some few figures. So I saw on the website of the Ghana Health Service as I was preparing for this program, I realized that as of the 28th of March, we had conducted 2,519 tests with 141 positive cases. By 28th April, the number of tests had increased by some 111,000 to 113,497 with 2,074 positive cases. By 31st May, we had increased testing by 115,000 to 219,000, with the number of positive cases being 8,297. That's an increase of 6,000. Now, if you look at end of June, we had actually tested about 300,000, but the number of positive cases had increased by about 10,000 to in excess of 18,000. But the instructive thing is that we actually, engaged on a lockdown from the 30th of March. And then after 3 weeks, on the 21st of April, we lifted the lockdown. And in June, we began easing of restrictions starting from the 5th of June, where we opened churches and then schools started reopening. Would you say that, these easing of restrictions and also the lifting of lockdown would have contributed to the increasing rate of positive cases?
You see, thanks, Winston. It's an interesting question. If you listen to the president in all his addresses through the changing of the gears as we try to ease restrictions, one thing was obvious. He was banking on the Ghanaians' ability to show some sense of responsibility and discipline. That hasn't happened. So if anything, we haven't gone down the route that the president expected us to go down. As a result, if you look, the data you're talking about is correct. But I like to look at the epidemiological data slightly differently. So I like to look at the R value and I like to look at the doubling rate. The doubling rate is how long it will take for your cases to multiply by 2. And 3 weeks ago, our doubling rate was, I did some work for some people, and our doubling rate was 27 days. Today, I was going to do some work with a friend of mine, and it had dropped to 16 days. Right? So, and the range is 12 to 34 days. So, if you look at it from that point of view, and you look at our R value, which, looking at that same data, sits around 1.3, 1.4, depending on what you're looking at, with a range of 1.2 to 1.5. What that tells me is that if we don't do things properly, we have 18,000 cases now. Within a matter of between 12 and 34 days, we'll be looking at 36,000. So what needs to happen is that R value, the effective reproductive number, needs to come down. And it's not going to come down unless our behaviors change. So the progression you are seeing that you just pointed out from March to April to May and to June is in consonance with this changing of the gear regarding the speed of our polynomial curve. And therefore, unless we accept that we have a problem, in healthcare, there's something called a diagnosis. You have to effectively diagnose your pathological state, your disease condition. And then you predict the prognosis of where you're going. And it is the prognosis is based on the interventions you make. So if you leave the disease after diagnosing without doing anything, you have an idea what's going to happen. If you then prescribe medication, you have an idea what's going to happen. If you get the patient to understand how to take that medication and take it in concordance with their prescriber, where the patient becomes an active participator in their healthcare, you also know the direction the disease will take. They will live longer. That is what's happening here. We've diagnosed our problem. We know there's COVID in Ghana. No one can run away from it. We know the R naught of COVID worldwide has been calculated. And so if we leave it without doing anything, where the disease is going to go. We know the disease direction if we prescribe medication, interventions like social distancing and all that. And we also know if there's concordance, if the citizen will participate actively, and it isn't about the state having to enforce where the disease is going to go to. The direction we are on now is where the society is not concordant with the information that is coming from our public health leaders. And if that continues, then our trajectory is still going to be on the route where our doubling time will be between 12 and 34 days, with the mean being 16, 17 days. It wouldn't change.
So let's look at one thing. Now, I mean, yes, you've talked about all of that, but we're faced with a situation now where, I mean, over the next 30 days, people would have to go out there and register. Now, like you've seen in the videos, many of these persons, particularly in the capital cities, are not observing social distancing. There are instances where people go and are not even wearing face masks. Now, if this trend continues, it certainly will lead to an increase. But doesn't that also tell us that just maybe we took the wrong decision, or we made the wrong decision?
You see, I am someone who would argue for or against a decision based on the information available to me. And that is why I have had my arguments about any action that would be taken that would get people to congregate or aggregate. But I'm also someone where once a verdict has been given, and ultimately we voted for a president who makes decisions in this land. Once that verdict has been given, I go into the mode of working with the verdict to get the best possible outcome. So brooding over spilled milk and saying, oh, did we take the right decision? At this point in time, to me, is a non-starter. We would have enough time for a pathological review of how we've handled COVID this far when we are out of this pandemic. That is, if we get out of this pandemic. And I say if advisedly, because obviously currently there are no known treatments and there are no vaccines. So everything is supportive care. So I would rather we look at, in the next 30 days, we are going to have to register. What would we do to mitigate against our doubling time being less than a month and our R value being within the range of 1.2 and 1.6? That is what we need to, with the circumstances we find ourselves in, find a way of dropping these two numbers.
Okay.
And that is all we can do.
But with the circumstances we find ourselves in, can't we also then say we're putting this on hold? Can't we also say, well, based on the figures that are coming out, based on what we're seeing, we want to ensure that maybe we just stop this so we can take care, we can protect lives of people?
That is the responsibility of people in public service. It's the responsibility not even of the President of the Republic, but the responsibility of the Electoral Commission. Yes, there are public health interventions where the President, because he's sworn an oath to protect our well-being, may have a place to say that enough. But then that would be putting us into uncharted territory, because obviously the Supreme Court has also ruled about the independence of the Electoral Commission. And that is why I am saying that all these things would be subjected to critique when we get out of this. Because some of us are documenting a lot of these things, and we would be subjecting them to a toothpick comb to see if we made the right decisions at the right times or we made the wrong decisions at the right times. And what we can learn moving forward, especially when we know that this pathogen is going to stick around for quite some time. It's not something that is just going to go away and disappear into thin air. It's not going to happen. We all know that. Michael is a biologist. He probably can speak eloquently about this more than I can do. But at the moment, that decision hasn't been taken, Winston, and therefore we have to work within the confines of what we have. And all I would tell anyone listening to me is that at the end of the day, you have your health in your hand. I have written on social media today, and I'll repeat it on here. When it comes to mortality, it is a statistic only when it is someone else. But when it is you, your loved one, or an acquaintance, it's 100%. You bear the brand fully. And it is that sort of thinking that I believe we need to approach moving forward with this fight with, and realize that it is us that have to protect ourselves. We have the right and the responsibility to do so. The government ultimately bears the responsibility of our national security. But we also have to take our individual security seriously and protect it judiciously.
So you've talked about our behavior. I mean, you started by talking about our behavior. You've talked about how we need to protect ourselves. But you've seen the videos also. You've seen people going around. If you look at our behavior based on what you have seen, does it look like this is something that is achievable by way of changing our attitudes and our behavior?
I always say this. The word impossible spelled together means it cannot be done. When you hyphenate it, you get I am possible, meaning it can't be done. We have not found the linkage between the information we are putting out and conversion into education and behavioral change. Look, this pandemic affected other countries. And the behaviors anyone has been asked to engage in are not our default. They are not human default behaviors, social distancing and all that. But some countries, through discipline, have achieved it and have managed to drop their doubling time, reproductive number, etc., etc. I live in England. There are parts of England where now in Leicester, it's locked down again because the reproductive number has gone out of kilter. I live in Essex, and our prevalence rate has dropped by 65%. Now, there's something like 2.3 infections in 100,000 people. Why? Because in Essex, people have decided to take it seriously. In Leicester, they have decided to be laissez-faire with their life. And that is what I mean by one group has spelt it impossible, another group have abbreviated it, I am possible. Okay. It is up to us to make the difference.
We certainly would come back and make that difference. I've been joined this evening by Kwame Saponseli, who is a pharmacist and a fellow of CDD Ghana, and also Dr. Michael Owusu, who is a virologist at the Kumasi Center for Collaborative Research, KCCR. We're looking at Ghana's COVID situation. We're looking at our numbers. We're looking at some of the things that we can do to reduce our productive number and all of that. We continue right after the break. All right, so welcome back from that short break, and thank you so much for staying with us. This is UPfront on JoyNews channel. My name is Winston Amwa, and we have Dr. Michael Owusu, who is a virologist at KCCR, joining us, and also Kwame Saponseli, who is a pharmacist based in the UK, and also a fellow of CDD Ghana. So let me get to you, Dr. Michael Owusu. You've heard from Kwame. He's talked about some of the things he believes we're not doing well. But I'd ask you this question. So you are in there, you're conducting the test, you know that, you're conducting the test, you know the nature of the virus. In some jurisdictions, we've seen, restrictions in certain parts. Should we be doing same in Ghana?
Yes, so I think that my colleague Kwame Asiedu has made some very important statements, and these are things that should always guide us as to what we do with regards to managing pandemics of this nature. If you can recall the 6 WHO criteria for easing restrictions, the first one is to ensure that your transmission is under control. Mm-hmm. To know your transmission is under control is by looking at your effective reproductive number, of course. If this is below 1, then you know that you are on top. If this is above, then it means that the virus is on top of you. So these are things that you always use to guide you. But when it comes to making decisions with restrictions or easing, is something that you need to have a holistic view of all things and balance what the will of the people, as against what the people also need. This is where the balance has to be, and not just for government, but then the people themselves, including civil society groups, various political divides, the religious bodies. Everybody needs to come on board and understand what we need to do together so that we all share this burden together and move as a country. What many countries do is that when they further break their reproductive number at different, to the level of suburbs, to the level of region. So at a certain suburb, you can check the number of positives you are getting and restrict the suburb based on the new people they are getting, whilst you monitor their behavior and all that. So ordinarily, if some particular hotspots or suburbs are not behaving well, you will have to restrict them and then monitor what goes on. And then when you feel that things are properly, they are now beginning to do what they're supposed to do, then you ease. So this is what you call the dance and the hammer approach, what is one of the principles that people have used and written about in managing pandemics. If you want to go by the hammer approach, it means you have to lock down everybody, and you can't tell how long people will be locked down. So you always play around the R value, what they call the dance approach. So If your R value is increasing, you dance around it and bring it down. When it goes down, you ease and people move about. When it's up, you apply the hammer approach and beat it down until the point where you are able to manage it. And when your new cases begin to decline and things are almost settling, then you can begin to look at phases. So I think that is an experimental, more of something that you do. We have tried some options. We are relying on people's behavior to manage this. But you know that when it comes to Africa, sociocultural behavior within our own peculiar context, and Ebola has taught us a lot. Ebola killed over 10,000 people because of behavior. Because people want to go for funerals and they want to handle their dead bodies. People wouldn't maintain social distancing. People want to keep corpse bodies in their homes and move it about. So it killed a lot of people in Africa. So when it comes to using behavior alone, no matter how much you do, people will still want to do things that they feel is good for them. People still think it's a myth. People don't believe it exists. But then if you have 5% of people who don't believe it exists, they will behave in a way that will cost all of us. Because if they carry the virus, they put all of us at risk. If they don't wear a mask and you even wear a mask, you still have a risk of getting it from them. So I think that we may have to weigh the balance going forward. And for me, most will rely on the technocrats who are gathering information to make this available to the government as readily as much as possible, so that government will be able to look at this thing and review our options. If people are not behaving well, then of course the hammer approach needs to be applied. And when they begin to behave well and do what is right, then you have to provide some level of easing for them to go about the normal duty. It's not out of place for these things to be done. All over the world, people are beginning to monitor this thing and to apply both the hammer and the dance approach so that they can keep their new cases below some level and then manage the cases that come. If you don't do that, then the hospital begin to feel the pressure. And when they feel the pressure, with our limited resources and limited bed capacity, we are going to overburden the system, and that may not augur very well for us.
So finally, for you, Dr. Owusu, when you see videos of people going out there to register, not observing social distancing, not wearing masks, from where you sit, where you conduct tests, I mean, you are in the lab. How does it feel seeing these people going around, putting themselves at risk of contracting COVID-19?
It's quite disturbing, and not just for the people. And people always think of themselves. They don't think of others. The point is that when they do these things, we feel pressure in the lab because they bring more samples to us. It means you have to spend a lot of time to process these samples. And when you feel the pressure, you also are at higher risk of being infected yourself, because the more positive samples you process, the higher your risk of contracting the very thing you are handling. Not only those in the lab, but also in the hospitals, because as they behave like this, many of them may get sick, and they will all troop to the facilities and put the lives of the health workers themselves also at risk. So some will become infected, others will be displaced from the system. So you know how the virus behaves. It will displace people from the health facilities whilst increasing the cases. When you have consistent reduction in your health workforce, and you have beds that, of course, people are in and they don't have specialists to manage them, then, of course, you get to a point where, people you've seen on videos as other countries have gone through. So I think that people will have to learn to think right. And when they behave like that, they must think of other people who are managing these things, that whatever they do, the ripple effect will come to those of us in the lab, those of us in the hospitals. Those are people who are managing patients all over. So if people understand these things from this perspective, perhaps they may want to rethink of their behavior and do what is right. And like my colleague said, perhaps what we have to do, for me, maybe perhaps put some security men in all the police stations for them to enforce these kind of measures so people will behave well. If they see the military man in his wear somewhere standing by with his gun and stuff, perhaps they'll behave well, because they behave like this without thinking of others. But then when the military comes in, then they begin to comport themselves. I think some level of enforcement will help us, all of us, so we don't continue to have these new increasing cases, and then we can manage our health sector. For me, it's very dear to me. If we allow the health pressure to be put under pressure, then we will not, things will not go very well for
okay.
us.
You talked about putting those who even run the test at risk, lives at risk. As you go around your duties daily, are you scared? Is there any fear of contracting COVID-19?
Of course, not just for me, but for the number of staff who are always working. So every morning we do risk assessments. We ask people whether how they are feeling, if they have some headaches, if they have some fever. And if we feel you are having something, we have to involve the public health team, review you if possible, collect your sample, test you, and then we give you some counseling. But then every morning, if you wake up after testing and you see out of 100 samples, 30 become positive, of course, you ask yourself, people are not behaving well, so what am I handling? So psychologically, you feel the effect. And that is why when you go out there and you see people behaving in the way, they don't understand what they are dealing with. For those of us in the lab who know what we are handling, who understand the dynamics of the virus, what we know the virus itself can cause viral pneumonia. You can have other comorbidities. It's just one of the factors. It can kill it by itself. So if you know what this virus does, then you want to be extra careful in how to manage yourself. But as I said, the understanding of people and how they see things is something that for African countries is difficult to appreciate public health, epidemiology, and all those things. People find it difficult to appreciate this. And that is why sometimes some level of enforcement is what perhaps we need to enable us fall in line and do what is right.
Okay. Well, thank you very much, Dr. Michael Owusu, for joining us. Dr. Michael Owusu is a virologist at the Kumasi Center for Collaborative Research. Let me get to you, Kwame Sapon-Siedu, finally. Dr. Owusu's talked about his fear and all that. He's also talked about one thing that I'd like you to talk about briefly, health facilities, that if care is not taken, they're going to get full. Well, already we know that the treatment centers in some parts are getting full. And the last time you spoke on the Super Monitor, you talked about if our active cases exceed the number of doctors that we have, then it means we have a problem. Well, with a new mode of discharge and recoveries, we haven't gotten there yet, but we are getting there. At this point in time, we should be very scared, isn't it?
You see, I remember when Winston, the new definition of discharge came in. I made a post on Facebook where I said, I agree with the new protocol, but it is just a rebasing of our economy to borrow from economics. So the fundamentals of our active case increase had not changed, which is new cases and recoveries. Yes, there had been a bulk of recoveries, which were going to be carried off our active cases. But once that was done to rebase our epidemiological model, day on, day out, the new cases must be less than our recoveries for us to be able to bring this under control and avoid our health system being overrun. If you look in the last 7 days, on average, we add close to 190 to 200 net new cases. So you realize that our active cases have been growing since the low of about 3,400, 3,500 when the rebasing was done, to now we've added on about 1,000 more. So we are about 4,400, 4,500. What does that tell me? It tells me that if we continue down this trajectory of 200 cases, even if we decrease it to a net of 100, that is net, which means that the base number that we have now of 4,400 is not going to drop. So if you are adding 100 extra a day, that means you need 3,000 more cases. Or if you look at 4,400, 2,600 more cases for you to reach the threshold where our COVID patients are more than our doctors.
That would be all time would allow us, Kwame, unfortunately.
26, if you decide to be very conservative and go to 100, that's 26 days. If you decide to go to a doubling rate and look at our current growth rate of net 100 to 200, that's 13 days.
Okay.
Which agrees. So in 13 days' time, we should be looking at round about 7,000 active cases if nothing changes.
All right, Kwame. Unfortunately, that's all time would allow us. Thank you very much, Kwame Sapon-Sedu, who is a pharmacist and also a fellow of CDD Ghana. And thank you also, Dr. Michael Owusu. My name is Winston Amwa. That's all from us this evening. Up next is Joy News Prime. Have a lovely evening and keep watching the Joy News channel.